Well, hello, good evening, everyone. Welcome to another episode of Progressively Yours Health and Wellness Podcast. I'm Dr. Imani, Ma'at.
And I'm J. Bernard Kynes, Sr.
And we are excited about another show on health and wellness. We have a wonderful guest. But of course, before we introduce our wonderful guest, we'd like to always start by bringing ourselves down to get calm, centered, and balanced. And Bernard is really good at that. So I'm going to turn it over to him.
Thank you, Imani.
You're welcome.
Again, we are so delighted that you're joining us tonight to hear from Dr. Cynthia Elliott. And before we begin, our spiritual opening involves welcoming and inviting the ancestors, those who have gone before us and who are in support of our health and wellness in a very spiritual way. So I'd like to invite those of you who would like to participate, if you're seated, if you're standing, just to take a moment to close your eyes. And I want to invite you to take in 3, what I refer to as cleansing breaths. Breath is symbolic of the spirit, in and out through the nose. On each exhalation, just let your shoulders drop, let yourself relax so that you can receive the information that Dr. Elliott is going to share with us tonight. Pay homage to our ancestors as they share in our show, our podcast on health and wellness for the enhancement, growth, and transformation of our people. And so as we come now, we thank each of you for your presence. Open our hearts and we welcome you to invite any ancestral or spiritual guide to be with you so that you might receive something tonight that would be beneficial for your journey in health and wellness. It is for the ancestors that we come at this time. Ashe,
Ashe.
Namaste,
Namaste.
Amen.
Amen.
Thank you.
Thank you, Bernard.
You're welcome.
That always feels good. That always feels good. And I, true to form, would like to share a little positive affirmation. This is from my 2014 calendar, Stepping into My Power Productions, the monthly affirmations for the inner child in each of us. A beautiful granddaughter there. Anyway. So this particular affirmation, and I kind of blend affirmations and acronyms. This one is on being joyful, and I had it open to the page. Here we go. So, find and live joy throughout every experience in your life. It may be a celebration that you made it through an experience and were able to survive. Focus on the positive and be glad that you made it. Know that it takes more energy to frown than to smile. Smile more and share laughter with your friends and family. Try laugh yoga. There's documented health benefits of laughing. Your body doesn't know if you're faking it or laughing for real. It is amazing. This month, I will laugh more and consciously practice being more joyful. And I spelled out joyful as an acronym to mean I prefer to be jubilantly over yesterday's feelings of unhappiness and loss. Ashe.
Ashe. Thank you.
You're welcome. And so it gives me a great pleasure to introduce our guest. And I love having guests that I don't personally know because I get to learn a new person and new information. So I hope you all have your pens out or your computers, whatever you type on or take notes on. And also feel free during the discussion to, depending on what medium you're on, you can always ask questions and we can field them at the appropriate time. Mm-hmm. So our guest this evening is Dr. Cynthia Lawrence Dugas Elliott, MD. She is a practicing rheumatologist for more than 25 years at the North Georgia Rheumatology Group, located in Lawrenceville, Georgia, in Gwinnett County. Her practice facilitates management of rheumatological and immunological diseases such as rheumatoid arthritis, systemic lupus, something I can't pronounce, psoriatic, it's supposed to be funny, psoriatic arthritis, and osteoporosis. Her practice participates in extensive clinical research, patient education, outreach services, and clinical rotations for medical students and nurse practitioners. The North Georgia Rheumatology Group provides an active infusion center for the biological treatment of diseases of the autoimmune system and connective tissue diseases. She serves as a member of numerous medical advisory boards within the pharmaceutical industry and in the public sector. She serves as a patient advocate, presenting issues concerning disparities in healthcare and gender disparities, with presentations in Washington, D.C., and in state and local government. It is my distinct pleasure to introduce Dr. Cynthia Elliott.
Yes.
Yay.
Welcome, Dr. Elliott.
Thank you very much for this I'm humbled, first of all, and I thank you for the very great honor of being in your presence tonight. I am amazed by all that you have done and all the outreach that you manifest. I take this opportunity with great enthusiasm to tell you about my particular passion of the marginalized attitudes that society in our country and globally has exhibited towards the healthcare of African Americans and people of African and brown descent, brown and African Americans. I think people of all diverse genetic groups. And the focus tonight for me is arthritis in African Americans, but I take issue with the global content. There is great disparity, inequity, and injustice in healthcare in people of minority backgrounds. I'd like to tell you a little bit about my perspective as an immunologist who sees inflammatory conditions in more than 400 or more disparate conditions that have inflammatory onset. Arthritis is very common. We all consider arthritis as a global phenomenon, but let's understand arthritis. Then I would like to, from my perspective, tell you how the inflammation in these diseases can result in a systemic disease that affects the kidney, one of the most important organs in the body. You hear about the kidney being damaged with hypertension and sickle cell disease and many other disorders. But from the perspective of an immunologist and rheumatologist, I see the disparate effect on the kidney through the arthritides. Let's understand arthritis. It's a word that refers to more than, as I said, 400 types of diseases. And these conditions affect, of course, joints and tissues around the joints. And some of these diseases can affect other parts of the body. And I would like to concentrate on the kidney because that, it seems to me, so globally impacted. And the damage to that disease, that condition, or that organ can cause conditions that are life-threatening and sometimes terminal. So I said, skin, internal organs, and joints and tissues around tendons can be impacted. We know that arthritis causes stiffness, swelling, and deformity of joints, results in limited ability of the joints. Okay, the severity is different from person to person. And from day to day, people only who are affected can only realize or sense the condition intermittently. But one of the axioms I teach my students is that the progression of disease can proceed asymptomatically. That's radiographically, that's in x-rays or in ultrasounds or different modalities that we measure. And we may not sense it. Well, can you imagine that the kidney can be the most insidiously affected organ? Yes, arthritis can affect the kidney.
Dr. Elliott, can you just tell us a little bit about why you're seeing higher rates of arthritis? What do you think is contributing to that? Not think, I mean, you're the expert. Tell our listeners what's going on, why we're seeing more arthritis. Is it?
Well, I hope we're seeing more because it's being recognized. First of all, it's very important because many diseases are caused by inflammation. You hear about the gut and the inflammatory process that proceeds from a leaky gut.
Right.
That can proceed to inflame or cause chemicals that invade the blood, that then, of course, pervade the joint tissues, the skin. I was going to elaborate that these are protective organs. The skin is an organ. The joints are organs. The tendons, the inflammation can absorb into those areas and then affect adversely organs. And I just wanted to concentrate on one organ, the kidney, because so many diseases cause inflammation, diabetes, and so forth. But arthritis is sort of under-recognized. And then you said, why is so much more being recognized? Well, because we're calling attention to it. It's global. It's ubiquitous. It's everywhere. We all deteriorate at various rates, and we all have exposure to what we call inflammasomes. These are chemicals that can cause inflammation in joints, such as, and I'll get to the quick, there's, in my opinion, marketable disease, okay? Marketable racism. Inflammation is more abundant if there are places or exposure to toxins, to tobacco, that's a toxin, to industrial pollutants, to toxic water, to food that may be contaminated. So we're getting more arthritis because that joints are one of the organs, and certainly one of the most predominant organs, or organ systems, I should say, that would absorb toxins and waste, and subsequently can result in joint damage and joint inflammation. So we may feel it more more abundantly, I think, in populations, and that would prompt people to go to the doctor with joint pain. But that pain could be ignored. That's the thing. We don't ignore pain, but we present pain to our specialist, and that's our structural intro into the recognition of arthritis. But my concern is that it is ignored. It's not picked up. It's not recognized as often as it should, because there's not as much competency in the doctors who see our patients. First of all, they think that maybe pain seeking is due to dependency on drugs. They think that sometimes it's a fibromyalgia, which may not have a clear, concise, systematic approach to treatment, but for marginalized care. But the root of the pain may be pathological and needs recognition as to one of those 400 or hundreds of types of arthritis conditions that need to be recognized and treated before it actually becomes centered into a major organ system, such as the heart, the circulation. Now, one of the major organs of circulation is the kidney. And my concern, and I wanted to express my passion about competency with our clinicians, recognizing the inflammation, such as in arthritis conditions. Let's just say lupus. Everyone's heard of lupus, just about. One of the major organ systems that captures the inflammation in lupus, maybe the kidney. Now, we could block some of that inflammatory entry by first monitoring what comes into our communities. We have so many toxins and wastes that are not monitored, and it's a structural competency that I'm concerned with in our marginalized communities. And as an African American, I feel that there's more that we need to know in data about race. We don't really understand how racism can shape and experience our healthcare. We are really having disparate recognition of, say, kidney disease, because we're not recognizing, first, we're not identifying the causes of the kidney disease. I think that tobacco is an equal opportunity killer. We have too much tobacco in our communities. So tobacco, we have a lack of recognition of early kidney disease, and these factors in our community, such as tobacco, such as lack of even pharmacies to provide medication, cause disparate health care. Eventually, we have lack of recognition of the diseases that are inflammatory, particularly in arthritis. As we're saying, we have less recognition, but so much more arthritis, but it's not being actually designated as associated with severity or intensity. So what happens? People have arthritis. They don't have it recognized as causing a terminal illness or a chronic disease such as kidney disease. Kidney disease is one of the most devastating endpoints of arthritis conditions, as is pulmonary and cardiac. But I wanted to just mention that because kidney disease is simply so inequitably treated and invariably will be inequitably, modified in the healthcare of most individuals. For instance, in the endpoint of kidney disease, a transplant will be less likely, like maybe one in, I won't even say the statistics, is very, very low. In kidney transplant provision for people who are marginalized in our racial or ethnic group, it's very unlikely that a kidney transplant would be available. And first of all, we don't donate enough kidneys ourselves, but of course we are marginalized by receiving that health care. We're ignored in a lot of cases with recognition of kidney disease, and then we're not getting the care that we need to minimize and modify the eventual outcomes. So we're at the center of the axis around this discourse of health disparities. And I hope I'm not going too far into the realm of the long-term outcomes, but we need to get more qualitative appraisals in our communities as to how we can minimize the disparities of recognition of kidney disease, and first treating the causes, like for instance, in my perspective, for arthritis, getting better early recognition of the inflammation, the intensity or the severity. Even those who treat sickle cell disease, getting earlier care so that we don't have the outcomes that are terminal as we're seeing in our community. We need more structural competency is what I'm saying, as a core of what we can do to minimize, enhance the long-term outcomes of diseases. our future directions, I think, have to bear very much a big weight on research and information systems within our communities. We need to let people know why should we not smoke? Why should we be more informed about the disparities in our communities in terms of long-term health care? Why should we not get more politically involved to find out who and where we're getting advocacy for better health care? My husband has hypertension. He didn't even know that he needed to have a nephrologist, a kidney specialist, also see him. He was only seeing a primary care and a cardiologist. We have to have more structural competency, more education as to the long-term benefit of early recognition of diseases, the pathway of the diseases, that they can start with inflammation in your joints and then realize that inflammation, what is inflammation, okay? What is the inflammation to begin with? And understanding those things depends on advocating patient education in our churches, in our school systems.
Can I interrupt for a second? You're bringing me back to my days. I was formerly the director of a huge health disparities project at CDC, Reach 2010. And one of the things, and I hear you saying this, is that we funded communities to look at chronic diseases, not just from the standpoint of the physicians, but we had communities that brought in non-traditional health and wellness partners, such as schools, such as fire departments, such as, oh my goodness, we had so many different components, the churches, of course, and it made for a better, a more holistic approach to looking at health issues and why people were just dealing with pain, why people weren't going for treatment and care. Other issues came up, such of course, as the scarcity of medical centers. We had a horrendous experience right here in Atlanta with an ER, right in Decatur, Georgia. And, we were just so surprised at the lack of staff that were available, at the amount of time it was taking for people to get emergency care. So, there are a lot of issues, and people get turned off and get frustrated because of the lack of services. I mean, that's just one level, in addition to everything else that you mentioned around environment, diet, and those other factors as well. But yeah, it's a big issue. And anyway, I just wanted to interject that about Reach. I believe Reach 2010 is still in some way, shape, or form still working with communities to come up with non-traditional approaches to information, diagnosis and treatment of chronic diseases.
I thank you for that input. That brings it really to home base. I look at it from the perspective of joint inflammation presenting to me, and then I look at the endpoint sometimes being fatal kidney disease. And I just had, we've almost lost patients recently, and thank God we've gotten more medication through research that I participate in as well. But the research has shown that there are disparities in ethnic groups. And as I said earlier, it may be the presentations early recognition is the key to target therapy and treatment that would avoid fatal and sometimes devastating conditions that in our families, certainly in our community. If a person has notice signs early on and get recognition, and of course that's where the structural competency comes in with the clinicians, like you said. You have to have a clinician that, first of all, you trust, that's going to listen and be discerning to recognize what's going on, because many times, and this is one of my big things, cultural competency in the medical field. You don't understand sometimes how we talk to one another or how our head language. I had a patient just now, one of my students came out to say, she's angry. This woman's angry. She's waited so long. She's angry, and she's really, really. and this happened to be, I think she was a Russian student. I'll just say that because she was Russian, and she had a language issue, but there was a cultural barrier there in terms of her competency and understanding. I went in, the woman was not angry, not at all, but her demeanor was such that she was in pain. Number one, she had been misrepresented, and her prior encounters with clinicians was that she was they were being dismissive with her, and she was trying to explain that she was so tired of being in pain and not being diagnosed, and she was just really very frustrated, and her head language was something that we would have understood as just something of her communication. You know?
Right.
She wasn't angry at all, and I mean, I just can't even go to the extent of how really upsetting it was to see that cultural competency once again is so lacking. And so my goal with one of the associations I'm involved with is to help train other physicians of other cultures how to discern and distinguish communications and certainly cultural competency with people of various diverse ethnic backgrounds, cultures, and demographic strata, so that they can get past all the weeds and get to the point for early diagnosis, treatment, just because you have to get history and you have to, it's input, it's assessments and proper diagnostic tools, applying the knowledge that we have and the skills and training with the history taking. If you can't communicate to your clinician early on what your symptoms, and certainly they won't even look for the signs because they're not even going to touch you. Some of them, let's be honest. Many of us have had physical exams where the clinician doesn't even touch you. So cultural competency is number one before we can get to the structural competency of how to promote medical education, enhance education, get to research, get to safety protocols and treatment to prevent some of the terminal illnesses. And right now I'm talking about the devastating condition of kidney disease, the disaster of kidney disease, which can be avoided, especially with medications that we have.
Dr. Elliott, just to, we can come back to that. I want to shift just a little, share with our listening audience how this area in particular became such a passion for you. What drew you to this area? What's a story about Dr. Elliott that kind of motivated you to want to be an advocate for our community?
First of all, I came into the realization that immunology and rheumatology were a passion for me. My grandmother had rheumatoid arthritis, I believe, to this day. She had inflammatory arthritis, became crippled. And my maternal grandmother and my sisters and my brother and I assisted my mother and father in her caretaking. None of the doctors were able to really treat her symptoms. She suffered, she ate, she had no modification of her pain, her swollen joints. And eventually there were other comorbid, we call them, other conditions that evolved from her lack of care. And it all evolved, I believe, from maybe hypertension, as well as the inflammation that ensued in her joints that was propagated throughout her system. And organ failure was seen not only in her, but in other family members from inflammation. And I wanted to understand what this process of inflammation was about and how could it be slowed down or modified, is another word, or put into remission, stopped. So I saw family members suffer with conditions that were inflammatory. One particular instance is my cousin, with symptoms that a young Black male who was thought to have had pain that was, what do we call it? That was, I'll say made up, okay? Was magnified. And pain seeking. He had kidney failure and it was due to an underlying inflammatory condition that wasn't recognized. Of course, he was an African American. His symptoms were overlooked for many years, and in his 30s, he became kidney impaired after having under-recognized conditions and symptoms. No good communication, no competency with cultural understanding of what he was trying to express. He required a kidney transplant and almost died while he was awaiting a kidney transplant because he wasn't up high on the list. We found out, he was in Boston, we found out that if he were to have a certain geographical or demographic presence, that he might be placed higher on the list. So he changed his clinical care to another area, and he was put higher up on the list.
Wow.
But it was something, and he almost died waiting for the kidney, just because he was in a certain demographic area, wasn't expressed as a need, even though he's a young Black man with a family working. I mean, he was anyway. We know that there was a miscommunication early on, and he was almost devastated. By the grace of God, he finally was assigned a kidney. It's healthy right now, praise God. But he almost died just because of a lack of care. And it could have happened 20 years ago that they could have recognized. He would have had to have the disparate understanding and diagnosis that he had. Recently, there was another instance where someone didn't get a transplant. Anyway, this is what happens in our community. If we're not understood early, recognition does not avail. We can have terminal illnesses and certainly loss of life. If disability is a case, well, that would be fine. We could just get some disability and keep on going. But we're talking about life-threatening diseases, and our people. I mean, I just see it every day from this position of people telling me, "No one ever listened to me, doc." You're the first person who's listened to me. We take time with our patients. That's why sometimes you do have to wait, but we're going to take that time and listen, get that history taking, and understand, so we can get a future direction that will result, hopefully, in a moderation of longevity. We can do something. But I talk about enhanced education. I want us to first be self-motivated. Of course, I was listening to scripture this morning. We have to be first, have good initiative, giving, I think it's Proverbs 19:17. If we lend to the poor, if we listen or lend to the poor, then God will replace all that we give. But we have to first be willing to give, to reach out and understand. And if we don't do that first, then how will people respond and give us back to us that very needed receptivity? First, we're not going to be receptive to or trustworthy of our clinicians if we don't first reach out to the patients. Research is what I'm really trying to enforce in our community. We're not going to be trustworthy to participate in research projects to ensure better treatment protocols if people don't communicate with one another to entrust. So we really have to be more engaged in education in our communities. That's where I first step out, and I've asked the pharmaceutical companies to invest in programs to get education. If you're not well aware or educated or better understanding of where symptoms can lead, then you're not going to go to a clinician. You're not going to invest the time. Even most people will say, "Oh, they're not going to." We don't even. And also, we're not going to be listened to or have any kind of input into our care. And most of us have a background, I know I do, of natural medicine, holistic care. So we're going to do that first, or we're going to ask, is that appropriate? And many times we're not, maybe people or certain ethnicities are not going to be receptive to the idea of holistic or natural medicine. And that's where we have some input as well.
That's a good point. And one of our persons in the listening audience said that it must be a holistic, and I'm assuming they cut their comment off, but I'm assuming a holistic approach. So can you say more about holistic by definition in this context? How do you define, what do you mean by holistic?
And how is it helpful in addition to what, the more allopathic approaches to diagnosis and treatment? What does introducing kind of the holistic approach, what does it bring to the table? Just so our audience can understand a little bit more.
First of all, I am an advocate of the holistic approach because that is sometimes a good barrier, initial barrier to the inflammasomes, the inflammatory chemicals that are expressed in our bodies, the microbiomes. These are the microbes that are populating our bodies that can start or initiate the inflammation to begin with, on top of our genetic predispositions. There is a very well documented body of information in science and research in the holistic realm. That when I say holistic, other than synthetic chemicals, the natural herbal formulations that God gave us from the earth can modify inflammation. That's all that may have been available for some of our ancestors. And they did not all expire spontaneously from the earth because they had knowledge of things that could modify inflammation, which we can go into another time. So yes, I think I'm answering your question. That may be the best approach initially, is to block the internal switches that cause inflammation through natural means, and to continue with that. The additive allopathic medications that we use certainly are more potent in many instances, or rapidly onsetting in modifying diseases. But some of the natural medications, although some may be deleterious in certain conditions and have to be minimized, most of the natural medications or natural herbal supplements, have a benefit. There's a place for natural and herbal medicine, absolutely. And I do advocate it in certain cases, such as turmeric. I'll mention some.
That's what I was thinking.
I'll say clove, which is a highly potent antioxidant. There are several. We can talk about more of them at another time. I'm very much appraised of holistic, I call it holistic, but natural medication. And going down the cytokine storm. Detoxification is first in my opinion.
Right. Drinking good water. We always talk about that.
Hydration is necessary and vital. Number 1, 2, 3. Okay. And then, of course, with that, detoxification.
So, Dr. Elliott, what should individuals pay attention to in their bodies as relates to inflammation, to cut off or to begin to address this kind of issue early on? What would you say to young people for prevention? Yeah, as a preventive measure.
Well, I mentioned one thing. First, stop the toxins if you can. I think I mentioned that tobacco is an equal opportunity killer.
Yeah.
Yes.
First, stop the noxious things in our environment, if we in our personal environment, if we can. Tobacco. I won't say gluten's first. I'll say first fructose. Synthetic sugars. Synthetic sugars. There are so many noxious toxins, preservatives, of course.
Wow.
Stopping things that are noxious. There's so many. So many things that we can avoid easily. Certain foods are inflammatory. Johns Hopkins has done studies that have justified the increase of mucus production in our bodies. I hate to tell you, but it's red meat and sugar and different things such as this that have been found to be inflammatory.
Even too much wheat and wheat and rice and other starches
wheat.
that are mucus producing. And when people cut back on that, I know in my 30s, maybe late 30s, I was getting stiffness in my joints, and I was doing most things right. I've been on the kind of natural path for some time, but I was one of those starchitarians, eating too much of the starchy things. And so my physician, who was also into natural health and wellness, he said, okay, I want you, Imani, for 1 week to not eat bread or rice, and as a Jamaican, we eat lots and lots of rice. That's been hard, but I've cut way back. But he said, cut back on the rice and the breads and the starches and do this for 1 week and call me and let me know how you feel. And I called him up and I'm like, pain's gone. He's like, that was pretty simple, and that might not work for everyone, but in general, we probably taken way too many starches and things that glue up our joints and our system. Right?
Gluten free. I mean, that is, I didn't want that second, but that is definitely a key point in trying to reduce the inflammation. So we're going back to inflammation. I'd like to stay there for a while.
Mm-hmm.
I have many patients who come to me, and this is another thing, this cultural competency. You have to have a trustworthy clinician. You would need to have someone you could talk to, and say, what do you think about this? Yes, mucus is a product of inflammation.
Mm-hmm. Mm-hmm.
And that mucus in the microcosm of things, or in the microscopic level, is what really is a part of the inflammatory cascade or event.
Right.
And so, yes, dietary modification, starting from the environment, is something we have to be selective about. I have patients that many times have told me that they would like to modify their diet and meet with them, format what they could do to minimize the inflammation. And we cut out gluten, we cut out L-fructose, we try to cut out, and that's hard, increase the hydration with pure water and filtered water. And of course, that's very difficult. And the carbohydrates, minimize carbohydrates.
Mm-hmm.
Sometimes it's hard to take out, to eliminate totally everything that's in our environment, because if you're not reading labels, we sometimes can't really scrutinize and be adaptive. But you have, and you really don't even know if the labels are there. What may be hidden? It might be in the small print. So difficult if you're not growing your own vegetables and not using fertilizers with all those genetic variants in them, and that's genetically modified corn and all.
We had a farmer on a couple shows ago, and she really broke it down in terms of the things that are added that shouldn't be added.
Oh, golly. And let's not go to meat and chicken and all the things that are, we get a veterinarian on here. It will really, you become, you would stop eating what we love the most, poultry. Toxins, and then we can get to parasites. Okay.
Right. That's a big culprit.
It is a culprit. Parasites on vegetables too, but the parasites that are in our meats.
Oh yeah.
So inflammatory that I mean, detoxing is number one. If we could get on to detoxification in a very structured way, I think we create longevity in our race alone, to the extent where we could see really a change in our outcomes, our health outcomes. But it's so difficult to get now, and I do introduce detoxification to my patients, and it's like talking to an impervious wall. What are you talking about? The meat.
It's a process, right? It's a process. But
that's where the trustworthiness comes in.
So Dr. Elliott, you mentioned earlier about something that I don't think many in our community are aware of or have been informed about, and that has to do with leaky gut. and the impact that leaky gut has in our overall system.
Mhm.
And my physician, who is also holistic, discovered that I had leaky gut and recommended that I do colonics, enemas to help clear my gut out, and put me on a very good product. It's called GI Revive,
Mhm.
that helps seal and tighten the lining in my stomach. Can you say more about leaky gut and how it presents a major problem for our health, and from your experience, some ways of healing / preventing?
Absolutely. First of all, I would be amiss if I were to say that that there's some people who probably don't have leaky gut.
Hmm.
The contrast is true. Most of us
Do.
undoubtedly have leaky gut. And that
Mhm.
accrues, well, that are over a certain age. We're not necessarily born with it, but our immune system breaks down, is deregulated, so that we are not protective against noxious waste, toxins, environmental pollutants, dietary wastes, and products that are harmful, that break the lining of the gut.
Mm.
What is leaky gut? Well, our gut is made to have a filtering process where we are able to eliminate certain not needed um, entities, I'll just say, or chemicals.
Mhm.
But when the openings, the doorway for that elimination is widened, it allows more proteins that are noxious, or things that are bacterial, or things that are I'll just say parasitic. They can pervade or go in. There's an entry and an exit. We're supposed to allow things to exit that are not needed, or that are not needed to come into our system to be eliminated, but more molecules of toxicity are allowed to come in when the openings are widened. And we call it leaky also because we're allowing good things to go out, or nutrients,
Mm.
but we're also allowing that opening allows noxious things to come into the gut and go back. The circulation is very fragile. We have blood vessels that are laying us right alongside the gut, and that brings the toxins and wastes, as well as bacteria and viruses. They float through the body. We'd like to get rid of those, but they're allowed to enter into the blood system through the gut. Okay. Wait. This is our entryway, the mouth. Okay.
Mhm.
We're taking in whatever that may be not needed. It
Mhm.
goes to the gut. We digest. The food has got the toxins in it. It's got bacteria. It's got noxious ingredients. It's got
Mhm.
chemicals, environmental pollutants, and they're in the gut. They're in there. Well, they're supposed to keep on going out, but we may have, by damage from chemical use, from just over bombardment, the little pores or exit valves, we'll say, are widened, and we may leak the noxious materials that are supposed to go through that conduit, the gut, which is, it's huge, it's long, it's like it's many feet long.
Right.
But there's a long corridor through which all these noxious things can travel, trying to get to the exit point. But meanwhile, there are all these little openings where the toxins can be exited into the bloodstream, which is just lined up like a little elevator or corridor on the outside of the, leaking from those widened areas of the gut into the blood vessel, and then carried back into the system. Well,
Wow.
and these bacteria, let's just say let's just say bacteria, okay? Let's just say bacteria. It goes back into the bloodstream, leaking from the gut, and can go back into the heart area, can go into the kidney area, can go into the pancreas, other areas of the body. The nasty, noxious entities that are in the gut absorb back into the bloodstream, which is there to actually take good things back into our nutrition. But it can take also these awful products into the circulation, recirculate them, leak right back into the circulation, and land into, say, the heart valves.
Wow.
And it's really a vicious cycle. You're supposed to eliminate, but if the gut walls are weak, they have stretched openings, or I'll call them interstices, but they're just areas where there are the ability to eliminate, escape particles that are not supposed to go back into the circulation. So yeah, leaky gut is pretty noxious, but what we all have is the ability to heal a leaky gut to certain extents, and we need to learn about that. And
How can we feel it?
One of the things is through cleansing, of detoxification. Now, I'm not going to mention the colonics that you have, because I'm not really skillful in talking about colonics. I do have relatives and even my husband who has had a colonic or two. I'm not sure that that's long lasting. Okay. We have to have an ongoing. Colonics are temporary. You just get that cleansing for then after that the period of time. It's probably one conduit, but does it get all of the caked up debris that's matted on the internal wall of the gut? I'm not so sure. I'd have to have a good colonic GI specialist or a GI specialist tell us, you get all that caked up gunk off the walls with a colonic. I'm not so sure, because it really is very difficult to eliminate what builds up on the internal wall of the GI tract.
Well, there's also fasting.
And there's fasting.
Different types of fasting, just juice fasting or liquid fasting, which I do. I actually have a group on Facebook called Monday and Intermittent Fasting.
Intermittent fasting is a good idea. Of course it is.
Yeah, because we tend to eat too much. I mean, and that's part of the problem too. We talk about the caked up things that are in there. We don't give our bodies a chance to digest. We just keep piling it. In this society, food is a very social, it's a social activity. That's so right. People are eating just because they're socializing with folks, not necessarily because they're hungry. So we're just piling it on. And so one way to get to that crud is to reduce how much we eat, right? And
absolutely
drink the good water, alkaline water, stuff like that.
Oh, alkaline water, absolutely. I've been a proponent of alkaline water for
I drink.
The thing is, which you can alkalinize your water with alkaline tabs. That's what we're told, but that's not always the purest alkaline water to just put those tabs in. And there have been so many just disparate information givers about alkaline water. So I'd like to have more information on what is the best alkaline water. I used to use a source, and I thought it was good, but I don't know. I mean, I paid good cents to but what is good alkaline water?
We both have Kangen machines, which is an ionizing, alkalizing system. It's very expensive, and a lot of people can't necessarily.
The Kangen. What did you say? Is it the Kangen or
Kangen? Kangen.
That's the one I thought you meant. It is very expensive.
Yeah. And we have links to that if people are interested in getting a system. I've had mine for about 14, 15 years. I mean, so they last, and we may say it's expensive, but people go out and buy sneakers for $500.
But may I ask you a question about that? Sure. I did a lot of research on Kangen, and an old technology. It's very, very well acclaimed, and there, as with everything else in life, there are modern techniques and other updates on how to accomplish a goal. And alkalinization with other filters and other companies, which are lesser priced, have evolved. And I would like to know, have you any information or any interest in learning about the other updated techniques for alkalinization of water? I understand the King and family has used the same techniques, but I'm not sure. Have they updated theirs so that it would be lesser expense to provide a greater population of the humanity to have alkaline water?
Yeah, they have financing available. I mean, people buy what they want to buy, basically. Kangen systems are not the only ones. I think they're top of the line, and there are others. There are things that look like what do you call those pitchers that have filters in them that alkalize. As a company, I mean, I even have people share stuff like that with me all the time. So there are other companies that are doing that. Now, whether you're going to get the same quality of water or not, it's debatable. But the thing is, once you start down that path of finding good water, people land where they need to land. Some people are happy with spring water. That's, if that's good for them. Some people say distilled water is dead water because there's nothing in it. There's no minerals or vitamins, anything in there. So people need to do their research and see what works for them, try different things, seek out. If not one size doesn't fit all, so to speak.
So I'm jumping
Thank you
in.
very much. Thank you.
Yeah,
You're welcome.
I'm jumping in because we have about 2 minutes remaining, Dr. Elliott, and we want to really thank you for what you're sharing tonight, but we want you to have a closing word to our listening audience. What would you like to encourage them based on health and wellness with respect to your conversation with us tonight and with your emphasis on inflammation and kidney disease? We have about 2 minutes.
Okay. Well, first of all, we just have to enhance our education. I think learning more about the diseases that can affect our population, particularly regarding kidney disease, since that's so abundant among our ethnicity. We can close the gap, I think, in the racial health outcomes, at least in this country, by identifying, confronting, and just getting to the root of racism as to why it's so hard to identify the causes of inflammation in our population, get to the root of the inequity. I think race-specific reasons should be identified systematically. There's a role in racism in this health inequities, and I think it goes to identifying the early detection, early detection of kidney disease in our population. There are a lot of systems that perpetuate this right in our communities.
Food supply.
About just not even identifying the use of holistic regimen in early treatment of diseases. Just cultural competency and understanding the things that we could do early on to identify. But there's a lot of racial inequity as to why eventually people wind up with end-stage renal disease. There's so much information to glean and to be obtained, and I just would want our communities to be inquisitive, to be self-advocating, bring people with them to the doctor, to get into what I call structural competency. I would personally want to enhance education and just explore the context and the reasons for measures that we could adapt. We as individuals need to be responsible, advocate for ourselves, early detection, and then get to equitable care, because there are treatment courses that are available to us if we get recognition and allow for that communication gap to be closed. That's all I can say right now, I think.
That's I mean, you've given us and our listeners a wealth of information, Dr. Elliott. We appreciate you so much. I mean, we definitely would love to have you back. We always re-invite our guests to come back and continue the discussion at some point. You see how we do it. It's sort of a give and take and a flow and sharing of information, and it's wonderful. So we appreciate you so much for joining us this evening, and we hope that you'll join us again at some point in the future. And maybe our producers can put your contact information up one more time in case people want to reach you.
And as they're doing that, I just want to announce to our audience that next week we will have the president of the Interdenominational Theological Center as our featured guest, the Reverend Dr. Matthew Wesley Williams, to talk about spiritual health and other matters around holistic health.
All right. That sounds good. Looking forward to that. Thanks again, Dr. Elliott.
Thank you, Dr. Elliott.
My pleasure. Thank you for inviting me.
You're so welcome. Good night, everyone.
Thanks for joining us.
Ashe.